I became really interested with disenfranchised grief because of, I think, my background, number one, in nursing, and number two, in education, and seeing how we react as professional caregivers after the fact of having walking through the path with the patient through their palliation, maybe through their end of life, watching them suffer, essentially. And what's the impact on ourselves as caregivers? So every day, all of us provide skilled and compassionate care to those who are suffering and need us. And through this care that we give, we're negotiating our own thoughts and feelings around that, which is very convoluted and very ethical, I believe. And in meeting and dealing with patients and families, it really truly has an effect on all of us. I wanted to explore this a bit further from my own experience of working with a nursing staff that is very small and seeing reactions and actions after the fact of being open for 9 years, and those of us who have been there, just watching the change in ourselves. So today what I'm hoping to do is explore issues of disenfranchised grief. What is it, and how does it relate to us? Through my research, I found that there are some definite consequences of living with and not acknowledging what disenfranchised grief is, what's being utilized. So disenfranchised grief basically was first defined back in 1989 by an author, or a professor, in New York, Doka, and he's also one of the main people in the American Association of Palliative Care and Hospice. So disenfranchised grief is a grief that a person experiences when they incur a loss that is not or cannot be openly acknowledged, publicly mourned, or socially supported. So looking again at the research around this, a lot of it started, disenfranchised grief started being the topic of choice, looking at reproductive loss. So women and men who, families who have lost maybe a miscarriage or stillbirth or something horrible happening, a physical incident or something to a family. And it was, I mean, as a society, how do we deal with that? How do we look at that? Another bit of the research in disenfranchised grief is looking at people who have lost a loved one to drug overdose or something associated with a social behavior. Also, our animals are pets, if we think about it in that aspect. It's not openly acknowledged, it's not publicly mourned, and it's not really socially supported. And then we get the cliches of, oh, you can just have another baby, or 3 times lucky if you've lost, 2 pregnancies, or it was just a dog. Basically, the way I've summed it up is just disenfranchised grief is not, it's not normal support that's forthcoming. The situation isn't necessarily normal. So when we take this grief and we put it in the context of the healthcare professional, it's not really publicly supported, right? Because we are supposed to suck it up as professionals, and we're the ones who signed up for this type of work that we do. There's a myth of closure that you close and you move on to the next patient, you move to the next room, you move to the next family, you just keep going. And it truly is, the research is showing that we compartmentalize the experiences, and those walls are eventually going to fall down. It becomes especially important when we look at disenfranchised grief because it's really unique in the profession of healthcare. We are a large body of people. And when I say healthcare, I'm including the nurses, the physicians, physio, RT, our nonprofit societies, our volunteers within that nonprofit society, or volunteers in general. Because we're taught that our emotions are supposed to be hidden. We're not supposed to really truly grieve and blubber over patients, so to speak. I've heard that so many times from my students, and where this myth has come from around, you know, not being able to grieve your family or the families of the person who's had the death or the death of the actual patient. Unacceptable. And when we genderize this, especially as this research has come quite apparent, I have the list of references at the end where I do have, where I found the research, the studies conducted with physicians, and especially 80% of them in the field are men who become physicians, and they feel that much more at a loss because men aren't supposed to cry. We're to stay strong despite circumstances, even if we have our own personal grief. So something for us happens, the loss of a loved one, we still have to go to work. And if we work in the field where patients die or are going to die or they're on the dying trajectory, it's hard for us not to have those emotions come to the surface, yet we are to suppress them, especially when we have short bereavement days. We're told to be objective and go in with a professional cap and leave with a personal cap, but it becomes very convoluted. And for some of us in the healthcare professions, we feel like we're not able to attach to everyone and therefore maybe feel some guilt in that. You also notice at the end with my referencing, most of the references I've found, I mean, there are several that go back to 2007, but very few. The research is more from 2010 on. So why is this happening now? Why are we looking at disenfranchised grief now in 2013? Well, we're taught these things. We're taught these things over and over again as professional caregivers, that we are to have a distancing from our emotions and from our attachments, and we're there to, you know, give the family care and keep boundaries. What I'm finding, though, is that there's a real lack of knowledge about what we're passing on to our colleagues and friends and students, and we're taught about guilt, too, in this, and I did touch on that. I just love this. I think this speaks volumes. I have to say my background, before I became a nurse, my background was art history. So if I can somehow attach a piece of art to teaching about nursing, it's just my way of doing things. I don't need therapy, I have wine. And this is very telling about what is actually showing us in the research now with consequences. What we're finding, and this is why I think disenfranchised grief and the research around that is coming to fruition, is because one of them, of course, I mean, there's so much that goes on in healthcare and for professional caregiving, but we're seeing a more increase of occupational stress. We're seeing an increase in sick time, and we are seeing an increase in horizontal violence in the workplace, although it's always been there. And this relates to, I believe, and from what the research says around horizontal violence, is from being suppressed. That's our history, is in this profession of nursing, that is, not necessarily all professions, but of suppression. And that suppression, I think, of guilt or of grief as well. We're being really suppressed. It's just upper lip, get going, we have 12 other beds to attend to, or we have another family coming through our doors that require counseling. Burnout's becoming something, unfortunately, that's prevalent in professional caregiving, whether it be volunteering, whether it be care aides, whether it be nursing assistants. We are seeing burnout happening, and there's a multitude of reasons why this is happening, but I think when we're looking specifically at disenfranchised grief, it's certainly lending itself to that. You may hear disenfranchised grief / compassion fatigue together, And there's no, I'm not really quite sure how to distinguish the two of them, but it certainly is, it describes it really well. I would say that compassion fatigue describes disenfranchised grief well. And just relating back to the previous slide, that we have and are accumulating core habits, coping mechanisms, and this I have found a vast amount of writing and journaling around alcohol consumption with people who work in end-of-life care and palliative care and chronic health care. That it's actually very sad to me, this alcohol consumption. That's in the article with the physicians that were interviewed, they talk and describe a lot around going home and having a drink or two, and it just kind of exacerbates after time. The post-traumatic stress disorder, mental health issues that are coming up. And again, the whole notion of us as caregivers forgetting about our own personal experiences, because what we know about giving excellent end-of-life care and palliative care is that a lot of us come to this field of work and love this work and are passionate about this work because we've had our own personal losses, and we're able to perhaps empathize at a greater level. Any questions or thoughts? Anybody like to interject here?
What you're describing here on this slide, Michelle, is really congruent with some of the recent presentations I've heard in the International Congress the last couple of times, where there's a growing understanding that this kind of, to use your phrase, the stiff upper lip and the emotions forbidden, that kind of philosophy is leading to profound isolation and depression for our health professionals. And there's a growing recognition that actually moving in closer, feeling free to forge a relationship, is actually the antidote to compassion fatigue. Whereas some of our previous education has told us set boundaries, pull back. Some of the current material talks about moving in.
Yeah, that's actually a very interesting thought, to engage with families and loved ones and their loved ones and explore that relationship.
And I guess I wonder if it's a little bit different in the palliative care world versus, say, nurses that work, let's say, acute care medicine. Because I wonder, for me, the reason I came into palliative care was because I wanted those connections. And I wonder if I don't know, you might be getting to that, but I wonder if there's any evidence of it being like maybe less compassion fatigue or less of this if you're in palliative care because you come here for the connection, or is it really not, that's not really what you're seeing?
And I don't formally have it presented here, but from what I've looked at and reviewed over the years, it seems to me that it's more in the realm of, in the arena of working with patients at end of life and through their disease process, rather than that quick meeting with in acute care facilities in terms of establishing the relationships and feeling the loss of the patient. What I've learned is those nurses who do work in acute care, who have the fleeting moments, so to speak, with patients who are palliative, the guilt there, or the compassion fatigue there, comes from the lack of knowledge around how to properly, so this is their words, how to do more for a palliative patient in a setting that doesn't support palliative services, right? Because they're there for medical intervention as opposed to end-of-life care, and that's sort of the research that I've looked at around that. I started my path, I'll just kind of curtail here, I started my my work in this around 2010. My supervisor in Lancaster University is a sociologist, or was a sociologist, and he was looking at disenfranchised grief with adults living with mental health disorders or disabilities. Down syndrome especially is where his field of research was, who lost an elderly parent because there was nowhere for these patients to go. I hate to call them patients, but for these grieving children to go after their parents died, because they lived in parents' home all their lives and ended up in institutions at very older ages. So this, I looked at this and said, you know, this is just so overwhelming. We have to dig deeper here, so I knew this is a good time to talk about iPANEL, and I think the work that we are doing with the integrative, palliative approach to nursing. What essentially iPANEL is, what our stance is to take the principles of palliative care and apply them to the care of people with life-limiting chronic conditions. Previously, end-of-life care and palliative care was thought, you know, 6 months or less to live, and this initiative that we're looking at is to start talking and thinking about what patients' wishes may or may not be, what end of life will look like for them. So the conversation around end of life with our patients starts earlier, and it starts in areas where people have chronic conditions, for example, renal units. Those conversations that normally we believe weren't started or can be started now, long before patients end up in end of life or a palliative unit, for example. So from the literature, the big things that we're finding are that there are critical incident stress debriefings that are going on to help alleviate compassionate fatigue, but those are when it's a critical incident, for example, so an ER or a situation like an accident or suicide. Yet there's nothing out there where it really talks about at the end of life, where it's not critical, where it's an expected death. They talk about self-management and self-care, but how do we do that? How do we care for ourselves? We're not really taught that skill either. We're not in a culture where it's valued to care for yourself. And in a profession that is a caring profession, many of us that are women, and our children come first, and our spouses come first, and our families come first. And by the time we get home and are able to kind of deflate, it's bedtime, and there's no time for ourselves. They say support and resources are out there for us for our own grief as professional caregivers, but as we know, it's costly, or we are limited with our benefit packages or bereavement leaves. I was interested in looking at what else could we possibly do. And within our own staffing especially, talking and debriefing, I found in both formally and informally, in units, on floors, in organizations. I know that there are several nonprofit societies here that do have debriefing sessions once a month when they have a patient who has been a long-term patient of theirs. For example, I'll just give you an example. The MS Society, they come to know their patients fairly well. A nonprofit, and there's volunteers involved, and there's an administrative staff that's involved that does rental programs and does supplies, and they come to know their patients over a long term. Same with nurses in the renal unit. You come to know your patients well, and when they're gone, it's a loss. It's a loss to the professional. That self-awareness and self-care, again, I'm going back to that. I think it's important that when we go down the list here, when you see my mentorship, orientation, education, that we include that as part of our orientation, mentorship, and education for new nurses, for new volunteers, for new staff members on our floor, how to actually do self-care. Some interventions that I've also found that have been helpful for staff and organizations are patient care conferences or roundtables, bereavement debriefing. But again, it's with the time press that are on organizations, it's very difficult to do this. And quite frankly, when you're done your shift, truly you just want to go home. Truly you just want to close your office because you've been seeing patients all day. You just want to go home. So these last 3 bullets here with the stars, I think, are key to how we're going to help disenfranchised grief and the professional caregiver. And I think a lot of it, as I said, had to do with mentorship, with orientation, and with education. So educating our students, whether they be medical students, respiratory therapy students, nursing students, CNAs, new physicians. And I think being mentors to people who are new to the floor, coming into our professions, wherever we may be, to show them that it's okay to express grief and loss over patients and families. To a point, right? Of course, we have boundaries in that we have to watch for, but I think it's really important to even acknowledge it and to let them know that they can acknowledge it and give that permission for people to acknowledge their grief. But I just wanted to show you my list of references here. I do have a couple of kind of neat articles. They are the links here on the bottom, the Nursing Times 2009 and the Canadian website for mental health, occupational health. So it is being acknowledged, which is great. So thank you all very much